Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Prediction of Survival by FDG PET in Patients with Locally Advanced Non-Small Cell Lung Cancer Undergoing Definitive Chemoradiation Therapy. Results of the ACRIN 6668 RTOG 0235 trial by Mitchell McTay et al. My name is Joe Salama, and I am an Associate Professor of Radiation Oncology at Duke University and Chief of Radiation Oncology at the Durham VA Medical Center in Durham, North Carolina. My oncologic specialty is the treatment of patients with lung cancer, head and neck cancer, and limited metastatic disease. In this issue of the journal, McTay and colleagues report the outcomes of ACRIN 6668 RTOG 0235, a large cooperative group study investigating the utility of a post-therapy PET scan in local regionally advanced non-small cell lung cancer patients following the completion of chemoradiotherapy to predict survival. To date, PET and PET-CT have been shown to be useful for many aspects of care for patients with local regionally advanced non-small cell lung cancer. PET has improved staging accuracy of non-small cell lung cancer, as demonstrated by the randomized PET START study conducted by the Ontario Clinical Oncology Group, demonstrating that the routine use of PET-CT improved overall survival compared to CT imaging alone, likely by routing patients to appropriate therapy at diagnosis, avoiding unnecessary treatment. Furthermore, PET has been shown to have a significant benefit when defining RT target volumes, particularly when differentiating tumor from atelectasis, resulting in smaller treatment volumes and lower mean radiation dose to the lung compared to radiation treatment plans based on CT alone, which combined should result in a lower risk of chemoradiotherapy-related toxicity. Furthermore, PET-based radiation treatment volumes are associated with a low 2% rate of progression outside of initial PET activity. In the current study, the authors hypothesized that perhaps PET imaging could be integrated further into the management algorithm for stage 3 inoperable non-small cell lung cancer as an early post-treatment imaging biomarker. This is an important question, as standard anatomic imaging, typically with CT, is difficult to interpret, and even those with radiographic responses may well have residual active cancer. Previous retrospective studies suggested that a metabolic complete response, defined as no abnormal tumor FDG uptake, following radiotherapy or chemoradiotherapy, was associated with improved survival, as illustrated by data from McManus and colleagues reporting metabolic complete responders had improved median survival at 31 months versus 11 months, and improved 2-year survival, 62% versus 30%, compared to those with a metabolic partial response. The use of FDG PET to assess response following chemoradiotherapy is common in other diseases. For example, in local regionally advanced head and neck cancer patients, a 12-week post-therapy PET has been adopted into standard treatment guidelines. This is because a metabolic complete response in cervical lymph node metastasis is associated with 100% neck control, obviating the need for neck dissection with its associated acute and late toxicities. Also, in esophageal cancer patients treated with definitive or preoperative chemoradiotherapy, a PET-CR, defined as SUV less than 3, has been associated with significantly improved survival, improved freedom from local failure, and a strong independent prognostic marker for all outcomes. Additionally, in some studies of esophageal cancer patients, post-chemoradiotherapy PET SUV level has been associated with pathologic response and survival. ACRIN 6668 RTOG 0235 was therefore practically designed to enroll patients with local regionally advanced inoperable non-small cell lung cancer, mainly stage 3, treated with concurrent platinum-based doublet chemotherapy and radiation therapy to a minimum dose of 60 Gray. Patients also had to have good performance status, ability to undergo FDG PET, and could have been enrolled in separate therapeutic clinical trials. Patients were required to have a baseline PET CT scan within 6 weeks of enrollment, and post-treatment PET required approximately 14 weeks after radiotherapy, and at least 4 weeks after the completion of adjuvant chemotherapy if given, both of these scans done on the same credentialed PET scanner. Both the pre- and post-treatment PET were assessed qualitatively and quantitatively for the more commonly used maximum standard uptake value, SUV max, as well as SUV peak, the median SUV defined within a small region of interest. Studies were interpreted both locally and also centrally by an ACRIN expert nuclear medicine physician blinded to the clinical data and institutional measurements, with images scored in a standardized fashion. Routine follow-up occurred according to best clinical practice over the next 2 years. The primary endpoint was to determine the relationship between post-treatment SUV peak and survival using a binary cutoff of greater or less than SUV peak 3.5. Additionally, several pre-planned secondary analyses were performed, including continuous SUV measurements, a 4-category model, and additional review of pre-treatment SUV levels as well. The study enrolled 250 patients, with 173 evaluable for the study. Table 1 shows us that both enrolled and eligible patients were split about 50-50 between stage 3A and 3B. 40% received concurrent carboplatin paclitaxel, likely explaining the number receiving adjuvant chemotherapy, as is common practice. Of note, the radiation doses used in this study were higher, 80 to 90% greater than 60 gray, than what is commonly currently recommended, perhaps reflecting concurrent enrollment on other RTOG studies, including RTOG 0617, which compared 60 versus 74 gray, recently reported to show no benefit to the higher dose. While the primary endpoint using a binary cutoff of SUV peak of 3.5 did not yield statistically significant differences in survival, pre-specified analyses of other SUV levels did. These included a binary division of SUV peak greater or less than 7, as well as SUV peak analyzed as a continuous variable, which became even more significant when using central review values. Additionally, post-hoc exploratory analyses also showed a binary cutoff of 5 significantly associated with survival independent of central or institutional review. The small number of patients with a post-treatment SUV peak of greater than 7 all died, validating this as an indicator for a particularly poor prognosis. Although one potential limitation of this study was the heterogeneous patient population with varying radiation doses delivered and systemic agents administered with radiotherapy, this variation is the norm in clinical practice and perhaps broadens the applicability of these results. The prospective nature of this study and relatively large sample size has added important information regarding the use of PET imaging for these patients. Based on Table 2 of the article, comparing pre- and post-treatment SUV max and SUV peak, clinicians now have an idea of reasonable response expectations that can be achieved on PET following chemo-RT. Secondly, analyses performed in this study also demonstrated that significant findings did not differ based on trial primary endpoint of SUV peak or the more commonly reported SUV max, aiding the applicability of these findings. Most importantly, the SUV max or peak found on a PET obtained approximately 14 weeks following the completion of concomitant chemoradiotherapy is now known to be associated with outcome. Patients with SUV peak or max less than 5 should be observed carefully, but will likely have better outcomes than those with SUV greater than 5. However, what is unclear following this study is what to do for those patients whose SUV remains greater than 5, or even worse, greater than 7. The authors recommend potential early additional therapy for these patients. However, it is unknown what this therapy should be, particularly as a Hoosier Oncology group and meta-analyses showed no benefit to consolidation chemotherapy following concomitant chemoradiotherapy, and many of these patients were not deemed candidates for surgical resection prior to chemoradiotherapy. Ongoing investigations may help to further the utility of FDG PET during the management of local regionally advanced non-small cell lung cancer patients to improve outcomes. The first strategy is by using FDG PET imaging during a course of chemoradiotherapy to predict outcomes after. Multiple small single-institution studies have demonstrated that FDG PET scans obtained during chemoradiotherapy can predict outcomes following the completion of therapy. Therefore, it seems reasonable, if PET response during therapy is inadequate, to alter course and attempt a different therapy, potentially in the form of intensified radiation or different systemic therapy with radiotherapy. A second strategy is to use a mid-treatment PET response to adapt radiation therapy dose and treatment volumes, which is being tested in RTOG 1106, ACRIN 6697, an ongoing randomized phase 2 study. Finally, FDG may not be the optimal radiopharmaceutical to use with PET, and studies are ongoing to determine if alternatives, including F18-fluoroL-thymidine, also known as FLT, or F18-fluoromazimidazole, may improve outcomes. In conclusion, while the current study adds another potential role for FDG PET in the management of local regionally advanced non-small cell lung cancer patients treated with chemoradiotherapy, there is still much more work to be done. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.